Welcome to Cardio Care Multi-Specialty Hospital. It's a hospital focused on cardiovascular internal medicine, and right now they are focused on high-end cardiology, interventional cardiology, cardiac surgery. We also do nephrology, dialysis, endocrinology, neurology. We hope that by February 2021, we will be starting open heart surgery so that people also don't have to travel abroad to have heart surgeries. You will also see the theater and a lot of the equipment that we've assembled. There's still a lot more on the high sea, and we really, at some point, are really just trusting God that something, just like we started this, the next step will also come through.
Good afternoon, everybody, once again. My name is Dr. Ofiswe, consultant physician with Cardiac Care Hospital. I'm here with Dr. Lalekon. Dr. Lalekon, good afternoon.
Good afternoon.
How are you doing, sir?
We're doing fine.
Okay, thank you all for joining us this afternoon. This afternoon, we'll be talking about a very interesting topic. We'll be talking about stroke, particularly how to prevent stroke. So our focus this afternoon will be on the preventative aspect of stroke, focusing on the clinical aspect of prevention, less on the public health and the population health related measures. So Dr. Lalekon, what should our audience expect this afternoon?
Okay. Again, we welcome our people to another session of clinical discussion. And today, our aim or the objective of this discussion is to let people know what the burden of stroke is, both globally and locally in our environments. We want people to know what the preventative measures are, different level of prevention measures, and how people can participate, because today we're not going to talk more about our use monitor, use
the
this,
stroke,
but we want to focus on the public health aspects of stroke. So at the end of the day, people will be able to understand how serious stroke is, what to do as for prevention, and how to engage the public in doing this.
Okay, absolutely. I think that's a very good one. And for me particularly, I think using the risk factor approach, I think understanding the major risk factors for stroke and then thinking how to handle each of those risk factors, because prevention is more like risk reduction, generally speaking.
Yes.
Okay, so I think if our audience is able to take this away at the end of today, I would say that we have done well. We've done a good job.
Yes.
Okay, so before we make things very complex, even as straightforward as stroke is, sometimes stroke is difficult to understand, to recognize, even to define it. So how would you, what is stroke in your own words?
Coming from what we used to know as definition of stroke when we were in medical school, there's been a lot of developments by the different bodies involved in stroke management to try and identify what stroke really is. And I think the World Stroke Organization, American Stroke Association, they come down with different improvements and definition of what stroke is. That now, once you are able to identify and establish area of focal infection in the brain,
focal infarction,
either in the brain, in the retina, or in the spinal cord, either by any form of neuroimaging, MRI, CT, or through pathology in case of autopsy.
Absolutely.
And you have an acute neurological dysfunction matched with that.
Absolutely.
That's the definition of
a stroke.
Okay.
So Okay. So basically, what you're saying is that if you can define that there is an area of infarction in the brain, in the spinal cord, or in the retina, either you defined it by neuroimaging, by clinical symptomatology, or by pathology. That's usually by postmortem. So you can say that person has had a stroke or has had a ischemic stroke, to be precise. Okay. And of course, using symptomatology from your slide here, it must have lasted for more than 24 hours.
Yes, and that is why what will differentiate it from a transient ischemic attack, which is transient, as the word is, less than 24 hours, but without evidence of infarction in the brain. Once there's evidence of infarction, even if the symptom resolve completely, the person's had a stroke.
So I've seen that kind of situation very, very often, that people will talk about someone having a partial stroke or someone having a TIA, but the person is still having weakness or residual symptoms for even a week or even 2 weeks after. If someone had, let's say, just slight weakness of one part of the face and it persisted for about 3 days, would that pass for a TIA, for instance?
Not really.
Okay. So,
because you expect TIA to resolve completely within 24 hours.
One, and then secondly, there should be no radiological demonstrated
infarction in the brain, spinal cord, or
absolutely. So basically TIA is like the angina or unstable angina equivalent of myocardial infarction.
Yes.
Once an infarction has happened, we can call it TIA again. Okay, what of the hemorrhagic component of stroke?
In the hemorrhagic component of stroke, what happens is you have a non-traumatic bleed, either into the brain or the subarachnoid space, and with the acute neurological dysfunctions associated with it. So that qualifies for.
Okay, so out of these kind of strokes that you discussed now, which kind of stroke is the commoner type that we see in our environment and globally?
Globally, ischemic stroke is a commonest type of stroke that we see, and it is understandable due to mainly the atherosclerotic lesion that underlies the pathology of the event. So it makes the prevalence of ischemic stroke more, almost about 68% and 32% of hemorrhagic stroke.
Generally speaking, for about 2 or 3 ischemic strokes you see, you probably see one ischemic subtype.
Yes.
So wait, how big of a problem is stroke now? How big of a figure, what kind of numbers are we talking about? How serious a problem is stroke? Often I ask my patients that, have you seen someone with stroke before? I've seen quite a few that have told me before that I've not seen someone with stroke before, but how common is stroke? How big a problem is stroke?
I think the challenge we have is the ability of people to recognize what stroke is.
Absolutely.
In this environment,
continue please.
In this environment, most of the time, what people refer to as stroke, as attack or whatever, mainly most of them are stroke, and people couldn't recognize it. And going by the global data, global body of disease, this is 2017. As of 2017, almost 12 million stroke happened each year. 2017, this is 2021. Imagine what we will have presently. And that means 1 in 4 people will have stroke in their lifetime. We can see how serious that is. And when I saw this, I was afraid that God forbid that in this room, God forbid.
That's a big number. So about 1 in 4 people above the age of 25 is going to have a stroke in their lifetime. So that lifetime is quite huge.
And that is why prevention is very, very important.
Okay, so before we go on these slides, how big is the economic burden of stroke? I know that many people who have had a stroke, they spend a lot of money in the hospital. If they require ICU care or neurosurgery, they spend much more money. And then, of course, a lot of them are unable to walk. Unfortunately, a lot of them are unable to walk. So I think the economic burden of any condition that causes disability can be quite huge.
Very huge. And the economic burden is even higher because the most affected age group is between 50 to 55.
Especially in Sub-Saharan Africa.
Especially in Sub-Saharan Africa, which is the main economic driver in this environment. So imagine the head of the family, the breadwinner of the family is down with stroke, cannot walk, money is not coming in, and you're spending money. So it makes the burden a lot more. And that is why WHO, all stroke organization everywhere, and us, we're talking about prevention. What can we do to make sure that, one, we don't even allow stroke to happen? And unfortunately, if there has been an episode of stroke, to make sure that we can try and make sure the person comes back as best as possible to his usual state and to prevent a recurrence of the stroke.
I would estimate that for an average person that has a stroke, they want to be treated properly in Nigeria, it will cost easily over ₦1 million, much easily over ₦1 million. because brain scan, admission require ICU care, multi-specialist investigations, evaluations, and all those kind of things. So I agree with you entirely that prevention should be our focus, particularly in this part of the world with our economic issues. Now I can see on the slide that stroke is the second most common cause of deaths and the third most common cause of disability.
Yes, worldwide.
Those are huge numbers, and
very huge number.
We also know that the risk of the occurrence of stroke is actually increasing, particularly in this part of the world.
Yes.
Because the key drivers like hypertension, diabetes, smoking, sedentary lifestyle are increasing. So it's not surprised that the rate of strokes are increasing. Now, I can see this relationship described between TIA and future stroke. What's the relationship between TIA and stroke?
TIA places the person at an increased risk of having a full-blown stroke in the future.
Yeah.
And after an initial TIA, there's an annual 3 to 4% increased risk of having a stroke. So if someone had TIA, that person needs to be more up and doing to make sure that those risk factors that have been identified are worked on, and we try as much as possible to make sure that the person does not suffer from a full-blown stroke, which result can be disastrous.
The other part I will try to mention regarding this TIA is that we should treat TIA as a medical emergency and is a serious urgency. So I've seen many people with TIAs that they have a clear-cut TIA and they just need to go home and just continue as if nothing happened. That, well, thank God that you escaped that. No. For someone with a TIA, apart from this increased risk of future stroke, the risk of a full-blown stroke, even within the first 24 to 48 hours, is actually very high.
Very high.
It's very high. And those kind of people need oftentimes to be admitted and to be put on aggressive risk reduction.
Yes, and we should not forget that the fact that someone had a TIA, the patient should still go for a CT.
Absolutely.
So don't answer, the person is better.
In fact, we cannot diagnose TIA without a CT scan because you have to exclude an infection by imaging. For all you know, it could still even be an ongoing ischemic stroke going on. Absolutely. Okay, thank you for highlighting that. So still on to the burden of stroke, coming home now to Sub-Saharan Africa. What's peculiar about stroke in Sub-Saharan Africa and Nigeria?
In Sub-Saharan Africa, we are fortunate that recently there was a study that was done looking at stroke in Nigeria and Ghana. Because before that period, actually, there has not been concrete community-based data, only anecdotal data from different centers. But now with SIREN, that is the Stroke Initiative Research and Educational Network, they were able to look at about 2,118 patients with stroke confirmed with neuroimaging in Nigeria and Ghana, and they were able to identify the pattern of stroke in Sub-Saharan Africa. From their own study too, ischemic stroke still came out to be the commonest, followed by hemorrhagic, and there were some in between that were actually difficult to please. And also, the age range that we talked about is still in the 50s, with the attendant economic burden associated with it. And another thing that was peculiar in that study was that they found that the traditional risk factors, that some of which we will mention later, which we usually think are common in the elderly age groups, are now commoner in the younger age group. So some of the traditional risk factors were even higher in the younger age group than the elderly age group, making it important for us to do a lot of awareness and focus on prevention. Because the meaning is that if these young people have all these risk factors, with time, the prevalence and incidence of stroke in the young age group will go up. So we need to do a lot more
than we're currently doing. So of course, we're going to talk about the risk factors for stroke shortly about now. So one of the main things you mentioned from the SIREN study is that we found that the age of stroke occurrence in our population is actually quite younger than it is in the West. And many of the traditional risk factors are even present, established in these younger age groups. So I can see here on this slide the most prevalent potentially modifiable risk factors among patients with stroke in descending order. So we're back to the same guy, hypertension.
Hypertension. Globally, hypertension is the most important risk factor
for stroke.
And the same is found in the Siren study. So we cannot stop talking about hypertension. We cannot stop talking about diabetes and problem with cholesterol, because these are the main driver of stroke globally and in our environment.
But unfortunately, we've had some myths about cholesterol recently that is actually distracting a lot of healthcare workers from cholesterol, as though total cholesterol and LDL cholesterol does not really matter and it doesn't affect the overall cardiovascular risk. What's your quick take on that?
Studies have shown that improving lipid, irrespective of what the baseline level is, reduce the incidence of stroke, reduce recurrence of stroke. And this is, we have sparkle studies, we have heart preventive studies with large number of people that showed that people with good control of lipid, they have better outcome compared to people without
good control. So from the modifiable risk factors that were detected in this siren, when they were highlighted from the siren studies, are there any surprises for you there?
The surprise in the siren studies were the discovery of increased intake of meats.
Yeah.
The psychological aspect is found that stress, increased meat intake and reduced intake of vegetables.
Absolutely.
They are major drivers in our environment. So good management of stress, both physical, psychosocial work, is very important. And healthy diets is also a key factor in stroke prevention in our environment.
Okay, so again, let's leave the siren study for now, and let's just go back again to talk about the risk factors for stroke. So let's talking generally now. What are the key risk factors for stroke? Let's talk about the non-modifiable ones.
Non-modifiable ones. We cannot do anything about that. Age.
Yeah.
We've always known that stroke is commoner in the elderly age group. Another one is family history.
Okay.
Another non-modifiable risk factor is also the gender. We know
yes.
Male, but within 35 to 45 age group, strokes are actually commoner in the female. So those things we cannot do anything about. Then there's some genetics predisposition, which we cannot do something about.
And then additionally, things like a previous history of stroke, we may not be able to do anything about that. So of course, as usual, our focus will be on the modifiable risk factor. And just from we highlighted from the siren studies now, the most potent one will always just be the main guys that we've always talked about: hypertension, dyslipidemia, hyperglycemia, and diabetes, obesity, which can be demonstrated by either high BMI or increased waist ratio, like we used in the siren study. And then going further, talk about things like excessive alcohol consumption, cigarette smoking, sedentary lifestyle, inadequate vegetable intake, and excessive consumption of red meat, or excessive meat consumption generally. So these things are things that we'll have to continuously put into context by the time we are seeing patients who we are assessing their cardiovascular risk. Now, we mentioned a lot of things here, but we've not talked about the hearts. So what are the cardiac risk factors for stroke?
Cardioembolic stroke risk factor, patient with atrial fibrillation. And we know with hypertension, hypertensive heart disease, we have a lot of patients with rhythm abnormalities. So atrial fibrillation is an important risk factor that we have to look after. The patient with valvular disease, infective endocarditis, patent foramen ovale, patient with myocardial infarction. Because with the increased incidence, prevalence of hypertension, diabetes, dyslipidemia, we're seeing more of people with ischemic heart disease.
Absolutely.
And they can also develop clots and they can have stroke from that. So those are the underlying heart conditions that we need to pay particular attention.
Before we go ahead, I would just like to remind us, just as we're talking about stroke now, that there are many times where we should easily suspect cardioembolic stroke. There are many things that typically suggest that a stroke may be cardioembolic, and part of the things we often see is that, number one, they tend to have recurrent strokes, even within a very short time. And oftentimes the stroke can peak and clear at a very rapid period. So if you see recurrent TIAs in a person, or if you see someone that you just get neurological deficits reaching maximal within a few moments and then resolving fairly on time, and then within the next 2 days, you're seeing another kind of ischemic events, those kind of patients, we should suspect that they could have a cardioembolic stroke. And of course, in those people, doing an ECG is mandatory, doing an echocardiography is mandatory, and of course, you can also go ahead to do a carotid Doppler ultrasound scan to look for carotid plaques and stenosis. Okay, looking at this slide, what do we have to take from this slide?
Like you said, hypertension is the largest risk, single risk for stroke. So that means if we control blood pressure, we would have solved almost 50% of the stroke issue. Then we'll talk of behavior that has to do with stopping alcohol, cigarettes, being physically active, and eating healthy.
Okay.
If we do those two, we would have almost
grossly reduce the risk
of modifiable risk factors.
Okay, so I think it's about time we look again at the preventive strategies for stroke. I know that by the time we're talking about prevention, the public health experts will usually talk about primary prevention. They talk about even primordial prevention sometimes, but let's talk about primary prevention, secondary prevention, and tertiary prevention. Primary prevention is basically people who will have had risk factors, and then we want the person not to develop a stroke in the first instance. So that's primary prevention. So someone that has hypertension, someone that has diabetes, someone that is getting older, anybody that has any of these risk factors for a stroke, generally speaking, and want to prevent the person from having a stroke ab initio.
And even in general population without the risk, want them to know the risk factors, try to prevent the risk factors from coming up. And for those with established risk factors, to be able to manage it and prevent them from having stroke at all. So that's the aim of the primary prevention.
So things like secondary prevention is someone who has already had a stroke or a TIA before, and we don't want this person to develop another stroke, or we don't want the person to develop a full-blown stroke in case of someone that's had a TIA before. So that's secondary prevention, whereas tertiary prevention is trying to prevent complications among those that had a stroke already.
Try to make the person as comfortable
as possible, rehabilitation, those kind of things. Of course, tertiary prevention. Of course, the aim of our presentation today will be a mixture of primary and
secondary.
Okay, so I think it's about time we just discuss a case to maybe stimulate our audience, as the case may be. Of course, we see stroke on a very regular basis. I still saw a potential stroke maybe about 1 or 2 hours ago. I'm still waiting for the brain scan result. But stroke is very common. I can remember the time I was in the teaching hospital, we saw about maybe 3 or 4 strokes per night. And that's the one that comes to the hospital. Some will die, will never get to the hospital. Some will not know that they had a stroke. Some will be managed for malaria or something or somewhere else. So stroke is actually very common in our environment. And I think we'll just use this case study to highlight something. So here's a man, a 68-year-old man, and he has a past medical history of type 2 diabetes, hypertension, paroxysmal atrial fibrillation, dyslipidemia, and BPH, that's benign prostatic hyperplasia. Interesting adding paroxysmal atrial fibrillation to this scenario here, because many people who have paroxysmal AFib actually is not documented, but you just know they get occasional palpitations, and then we're not really sure what's going on.
The pulse
as normalized.
It's normal.
Okay, so this person now has a past surgical history again of a left total knee replacement, right? Cataract surgery, removal of colonic polyp, previous percutaneous coronary intervention with a stent, and has previously been cardiovascular for atrial fibrillation. He's married with children, is a retired bar owner, and is a current smoker, 40-pack year history. Takes about 5 to 6 bottles of beer per week. And here is his list of medications. We have here lisinopril, metoprolol, aspirin, rivaroxaban, tamsulosin, vitamin D.
Before we move, can you see that the man has loads of risk factors?
He has loads of risk factors.
Loads
of risk factors.
Of risk factors.
And these kind of patients are becoming increasingly common.
Yes.
They have a lot of things going on, particularly in a center like Abuja, where there are many hospitals, people are healthy traits, and a lot of people go outside for their care. So people are living longer, and many conditions are more manageable.
Age,
absolutely,
with all different comorbidities. The malignant cases, these are even pro-thrombotic conditions that can predispose the man to development of clots everywhere.
Okay, so going further in the history, so this man was doing generally okay until a certain day when in the afternoon the wife was reported to have returned home and found the man lying on the floor. He had difficulty speaking, generating words, and he was unable to lift his right arm and leg off the floor. Upon getting to the hospital, the BP was very high. Here we see it's 190 over 110. The ECG was in sinus rhythm, and the CT scan shows a left middle cerebral artery ischemic stroke. What do you think about this?
This is one of the core factors in stroke. When we talk about fasts, we see that the attention was timing.
Yeah.
So that timing is very important because, like I said, time is neuron.
Absolutely.
The longer you wait, the more of the salvageable neuron that is lost in the process, and we can actually see that promptly the man got to the hospital, imaging was done, the lesion was identified, and he was able to get treated as fast as possible. That improves a lot what the outcome
of stroke.
Stroke is going to be.
So basically, from what you said now, I could say that part of the maybe secondary or tertiary prevention in stroke is recognizing the stroke early and acting on it to reduce the morbidities and disabilities that is associated with that stroke. So I think that's the important one, and that only will come by public education, awareness, enlightenment. Of course, ambulance systems may help a bit with that, and of course, increasing the ability of physicians to be able to recognize stroke early and then act fast as much as possible. So the question I will ask Dr. Lalekan is that in this kind of patients we have on this screen, would you consider this stroke to have been preventable?
Yes.
Okay.
From the initial study, we can see that attempts were made from some of the medication. You can see that is on blood pressure medication, is on anticoagulants, is on medication for metformin, but there are a lot of information we don't have.
Absolutely.
How the BP was 190, 110. We don't know whether the blood pressure control was good.
Absolutely.
Good blood sugar control, we don't know.
Absolutely.
We don't know the state of the lipid.
Absolutely.
We don't know how the history of follow-up, how good control of all these things.
And adherence to medications as well.
Yes. So those are the things that could have helped prevent what happened in the next slide.
Again, of course, we always put in view that reduction of the risk of stroke prevention is not an absolute thing.
Yes.
It's a risk reduction, and risk often may not be reducible to zero.
Yes.
Okay, but the risk can actually be greatly reduced, particularly by the time we talk about that slide we presented earlier, in which the modifiable risk factors occupies more than 80% of the risk related to stroke. So that means stroke can actually be prevented to about a 80% extent.
And even from the social history, they were still taking 40 packs of cigarettes
per day,
taking 5 beers. So we know that looking at smoking, alcohol,
absolutely,
that has not been
controlled.
done.
That has not been controlled
adequately. So
absolutely,
the risk are still there.
Okay, so I think that's interesting. So going forward to how this initial management of this patient was hospitalized from the stroke, stable recovery course, he regained partial use of the arm and leg, blood pressure was optimized, and it was discharged on additional antihypertensives. I was transferred to rehabilitation where he spent 3 weeks before discharging home to the wife, and upon discharge, he was able to ambulate with a cane and assistant. Well, I'll tell you that this story is not the same. It's not so for many stroke patients. A lot of factors come into play at site of care, whether they received prompt care, whether there was finances or healthcare coverage enough to make the care go as. But even beyond all of that, even sometimes everything is done right, and then the outcomes will not be this good. Some people have persistent disabilities, and then some people actually have a mortality from the stroke.
Yes.
So I think,
and also even in occasion where there is early presentation, how the patient is also managed.
Absolutely.
From the beginning. We can look at the blood pressure, how that was managed, how everything was done, because some action at that point could actually worsen the prognosis of the patient.
Absolutely, but of course, again, we'll try to focus on
prevention
this afternoon. Okay, so talking about the risk factors and the prevention of stroke. Of course, we have to start from the big one, hypertension. Hypertension constitutes way more than 50% of the overall risk for stroke. Both whether you're talking about ischemic or hemorrhagic stroke, and controlling high blood pressure alone goes a long way in reducing the risk for stroke. So what should we do regarding controlling? I'm sure almost all the doctors here, including me and you, see patients with hypertension every day. And that patient is actually a potential stroke patient someday. But sometimes I look at the patient's face and try to imagine the person unconscious and with a stroke, and I'll shake off that vision and I'll tell myself that I need to do everything to prevent that kind of event happening. So when we're seeing a patient with high blood pressure, what should we do in reducing the risk of a stroke for that person?
So in talking about this risk, we'll be talking both primary and secondary prevention at the same time. For primary prevention, hypertension in patients without a stroke, with other risk factors or without other risk factors. Like, as we know, we've discussed severally that latest figures, every 1 in 3 people you meet have high blood pressure.
Absolutely.
So for primary prevention, blood pressure must be adequately treated. And we have always been reminding ourselves that when we talk about treatment, we're not only talking about pharmacology, treatments, not only drugs, both lifestyle and drugs. So as a form of primary prevention, blood pressure must be well managed. For those with mild elevation of blood pressure, we can start with lifestyle modification, low salt, exercise, diet.
Now, when you say mild, because a lot of doctors get that twisted. When you say mild elevation, what kind of numbers are we talking about now? We're talking 160, 90, 160, 100?
We're talking of patients that has BP in the range of like 140, not more than 150. And say, okay, for the first few months, maybe 1-2 months, intensive lifestyle modification. Mark the word intensive.
Absolutely.
Monitored, structured.
And we should always really reassess, and if it's not working, start medication. Because I've seen many people who are on diet and lifestyle for their blood pressure, but it's not controlled for years until they develop heart failure, kidney failure, until they develop a stroke before they now consider starting medication.
I saw a woman 2 days ago, found to have high blood pressure, said, "Oh, we'll do lifestyle." And the woman now came on Tuesday with like something like amaurosis sugar. She was sitting in the house, everything just went blank. Wow. And after a while, she regained her vision back. When she got there, the blood pressure was 190 over something.
Wow.
And I just told her, "Madam, you just escaped a stroke." So this is not a matter of we'll do lifestyle. Okay. So the lifestyle, that's why we said supervised lifestyle, and we assess months at the end of the first month. If there's no improvement, we'll see. If the signs will be there, we start medication and control adequately, like we used to say, 130, 80, and thereabouts, and we continue to monitor. But for secondary prevention, we're talking of someone that
has had a stroke
already. If, like the case we present, if it's in an acute phase, the first 7 days of the stroke, and there is no sign of the mean arterial blood pressure is not so elevated. So within those few days, we can pause and not do anything about the blood pressure. But once we are out of that phase, we have to resume for those on BP drugs, and for those not previously on medication, we have to start them on blood pressure medication. The blood pressure is greater or equal to 140/90. Once we are out of that acute phase, the patient must be on blood pressure medication alongside other lifestyle modification.
Okay, talking about individualizing, number one, before I go to the individualizing blood pressure goals, what is considered to be a satisfactory blood pressure target for home reading? Because a lot of people mistake home readings for hospital reading.
Okay.
Targets.
Home reading for blood pressure are generally lower than hospital readings. So for home reading, by the time the daily average, 24-hour average of the BP is greater than 130/80, that is not normal.
That's not normal. Absolutely.
That's not normal. But if you want to do day and night, during the day is 135 less than 135/85. But by the time we do 24 hours, both day and night BP reading, it should be less than 130/80/80.
So we have a lot of patients that will tell you that the blood pressure at home is 142/90, that they think it's okay. But in the hospitals they get.
And there is this thing that for my age,
exactly, absolutely,
150/90 is okay. Yeah, no. 150/90 is not okay for any age.
It's not okay for any age. And of course, the only times where we need to make such considerations are for people who are frail, who have limited life expectancies. Yes, we can make some concessions sometimes, but we have to make sure that those concessions are not going to cause harm rather than give us clinical benefits for the patient. Of course, we have a lot of evidence to show us that controlling blood pressure actually reduces the risk of all cardiovascular events, actually, including stroke. I would say especially stroke in this environment.
Yes.
Especially stroke.
These are major 2 studies that were done using different medication, and that's why we talked about individualizing the regimen. You have to look at the individual. You have to look at other comorbidities to choose your medication. There is actually no medication out of all the group of the blood pressure medication we have that cannot be used for this patient to make sure that we reduce their blood pressure.
Okay, so I would just like to add, before we leave high blood pressure, that ambulatory blood pressure monitoring should be done when you're in doubt of a patient's control, or the patient keeps convincing us that don't worry, doctor, is just like this always in the hospital, and my BP is normal at home. You're getting 160/100 for the patient in the hospital, and it keeps convincing you that the BP is 110/70 at home. Please do an ambulatory reading. Let's see what the BP really looks like by 24-hour period. I've had a lot of nasty experiences related to that, in which the device was actually really faulty, or the technique for measuring at home was just totally wrong. So that we need to always put in mind as well. Again, additionally, this slide reminds us again that you can really reduce the risk of stroke by a lot. From this slide, about some 30 to 40% risk reduction just by controlling blood pressure.
And the risk reduction is even higher if you use a combination
of medication. Absolutely. Okay, thank you very much for that. So we address other risk factors as well, talking about stroke risk reduction now. So the other risk factors, I think one of the prominent one again is dyslipidemia.
Yes.
So dyslipidemia, what's the relationship between dyslipidemia and stroke risk?
Dyslipidemia is an important factor in the development of atherosclerosis.
Absolutely.
And like we said, that atherosclerosis accounts for greater percentage of factor in patients with ischemic stroke. So controlling lipid is a very, very key part of preventing stroke from happening, and also to prevent the recurrence of stroke.
And the benefit of that is both in the long term and in the short term. Because particularly using statins, because we know that atherosclerosis is a slow process which damages the wall of the arteries over years and narrowing. And so controlling the lipid over a long term gives us those benefits. But even also in the short term, particularly people who have had a acute stroke or who could have had an acute stroke, We know that the statins have the benefit of plaque stabilization and reducing the risk of occlusive events of the arteries. So,
and we should not also forget that statins in particular also have anti-thrombotic and anti-inflammatory effects. And also, a patient that has ischemic stroke will most likely also have arteriosclerotic vascular disease in other areas. So, peripheral arterial disease, coronary artery disease. So, statins is highly indicated in this group of patients.
What I've noticed is that many times doctors will forget the role of statins actually in cardiovascular disease. When we're prescribing statins for people, particularly in relation to dyslipidemia and cardiovascular risk, we should always remember to put the whole cardiovascular risk in the picture. So rule one is that someone with established cardiovascular disease, either a demonstrated coronary artery disease, demonstrated previous ischemic stroke, or demonstrable peripheral arterial disease should be on long-term statins, irrespective of the cholesterol level. That's one.
And also, we are also afraid of giving to some people 80 milligrams of atorvastatin looks as if, but actually, the studies that were done to show the effect of
the benefits
actually used high dose statins like 80 milligrams
for
those that can tolerate it to achieve. But for those that cannot tolerate it, we can do mid-intensity statin. That is about at least 20 milligrams of atorvastatin. So I've seen someone on 5 milligrams of atorvastatin is not doing anything.
Okay, what I also want to add to that is that for people who have dyslipidemia, anytime we're starting them afresh on statins, we should remember to put in context the whole cardiovascular picture and image. Okay, so if I have someone who's poorly controlled, high blood pressure, he has diabetes as well, and then the LDL is 130, I will give the person a statin compared to someone who did not have hypertension and diabetes. So I think there's that for statin benefit group released by the American College of Cardiologists. So I think we should review that so that the people that will benefit from statins we keep them, and then the people that have no business being on a statin we probably will take them off it. So I think that's important. And of course, when we put people on statin to reduce cardiovascular risk, we should assess the benefits. So for example, just today, I saw a woman, she's on 20 milligrams of atorvastatin actually. Her LDL cholesterol was about 230 something before. Today it was like 180 something. It's still high and she needs a higher dose. So I've stepped up her atorvastatin from 20 to 40. Now that's a higher dose, but I mean, we're not getting the LDL to target. So we should remember to monitor in that context so that if it's lifestyle you're doing for the dyslipidemia or if it's medications, we assess typically after about 3 months on a certain amount of treatment to assess that we're getting the desired results.
Then another thing to also notice especially in the SPARKLE trial of the lipid in patients with stroke is in some subgroup of patients, maybe patients with large infarction, patients that has high risk of hemorrhagic conversion, the use of statin actually increase the risk of hemorrhagic stroke in them. So we should watch out for that. And if neuroimaging confirmed that the patient had hemorrhagic stroke, we should not give the patient statin at that time until that is resolved. Then we can now be doing, maybe use that as a form of maybe secondary or tertiary prevention.
So I think that's key. I think that's is there a role for other? What kind of role do you think exists for other lipid modifying agents?
Yes,
they like also
they also have a place to play. One, if patient cannot tolerate statin, you have to use all these other agents to achieve your results. Sometimes even at that high intensity, you may not even achieve a good cholesterol control.
Absolutely.
So you may need to use multiple agents to correct that. So, but to start with statin, that's the one that has proven efficacy in both the primary and secondary.
So we should always put that in mind, because we'll always see that occasional patient that is on a FT dose of statin and then the lipid parameters are still quite awful, one, and then some patients will just be purely intolerant of the statins. Thank God we don't see so much of those. Okay, but we have them now and then, so we should be open to the other agents. I know that fibrates are available in our environment. Of course, the first step is actually to switch between statins. If a person is intolerant of atorvastatin, you can try rosuvastatin or pravastatin or one of the other available ones. Then, of course, if that's not working, then we can replace or combine with other agents.
But we have not really been using enough.
We'll not be using enough. Okay, so other risk factors for dyslipidemia, diabetes now.
This is another strong guy that needs to be looked into. I remember the last World Diabetic Day that we did. The incidence prevalence keeps increasing. And with that, the attendance risk of stroke. Diabetes is associated with 60% increased risk of recurrent stroke.
Absolutely.
So having diabetes alone place the patient at risk of having another one, and we know what the morbidity
is, and even outcomes is worse among patients with diabetes. The things I'll add is that the work of us healthcare professionals is actually immense. A lot of people who have diabetes are being seen by doctors actually not treated to go. They're not controlled. And by the time someone is not controlled for years with diabetes, atherosclerosis accelerates. It happens much, much faster, almost like that of a smoker. Okay, so we need to treat them to target. We need to make sure that their glycemia is controlled. As soon as people with diabetes who don't even know what an A1C is,
yes,
it shows that we, the healthcare professionals treating those kind of patients, we're probably not doing enough. So we should treat them to go. The patient should understand their glycemic targets, both in terms of fasting, post meals, and their A1C. So the patient should know whether they're meeting such goals or not. That is one. So the message in that angle is that the patients we are treating with diabetes, we should actually treat them, should get them controlled.
Yes.
So it's not like they're just coming to our clinics and their sugar is still high every day and then we keep excusing it.
We should follow the guideline.
Absolutely.
Diabetes in stroke is not managed because the patient has stroke. The blood sugar, the fasting blood sugar, the A1C can continue to be in 9%, 10%. No. That target of less than 7 should still be met in this group of patients. So we should follow the existing guideline, ADA, all the guidelines that there is.
And then secondly, like I was saying now, in patients who have acute stroke, we should identify diabetes. So it is compulsory to do a blood sugar test for anybody presenting with what looks like a stroke. So we should do that because hyperglycemia worsens the short-term outcomes of stroke, irrespective of whether it is a pre-existing diabetes, a newly diagnosed diabetes, or stress hyperglycemia, irrespective. Once the blood sugar, the random sugars is exceeding 180, 200, the outcome of that stroke is likely going to be worse. So we should identify it, and of course, acutely in people with stroke, we should treat diabetes to target. It improves the outcome of that stroke, and of course, it reduces the risk for recurrent stroke. So,
and we should not forget that even patients with impaired
glucose tolerance,
impaired fasting glucose level also have higher risk compared to other people with normal blood sugar. So those group two need to be adequately followed up. So it's not only people with frank diabetes that have increased risk of developing stroke or having recurrent stroke.
Okay, so that's it about diabetes, and of course, among patients with diabetes, we should also remember the other micro and macrovascular complications that occur, so that we keep our eye on the ball and nothing catches us by surprise.
Yes.
So we've discussed some key risk factors for stroke prevention. I've talked about hypertension, talked about dyslipidemia, talked about diabetes. I think if we do those three alone, we've really, I mean, if every doctor is doing that in Nigeria, I think we'll be seeing less strokes. We'll be seeing less strokes. And more people will work until the age of retirement without needing to start using a walking stick, need to be pushed in a wheelchair, or need to be live in a nursing home, so to say, because of disability. Okay, so of course, there are many other risk factors that we need to talk about. Talking about physical inactivity. What's the relation between physical activity and stroke, and what do we need to do as doctors?
Physical inactivity is linked to obesity, linked to metabolic syndrome in terms of central obesity, increased waist-hip ratio. Is also linked with dietary indiscretion.
Absolutely.
So this needs to be, because when we looked at hypertension and we look at lifestyle indiscretion, the two of them makes the whole bulk, and these two can easily be linked. The physical inactivity can also easily be linked to diabetes too.
Absolutely.
So we need to improve that, and that's why we talk about at least 30 to 40 minutes of physical activity that will make you to break your sweat, and that will also make your heart rate to increase
and make you pants at least a bit.
Yes.
Now, I think healthcare workers were not doing enough in this regard as well. I don't know. I've tried to cultivate the habit recently. In fact, I have a sticky note on the corner of my table that reminds me to ask patients how much exercise they are currently doing. I think it's something we need to be asking more often, and to find ways to motivate people. Patients actually don't get enough motivation to do the physical activity. They know that you check their blood pressure at the next visit, they know that you probably check their blood sugar, but they know that you probably won't ask about how much exercise they did in the last 1 week. Maybe there's no way for you to check it. I know that some of our colleagues in those days in UCH did these studies actually just gave the patient speedometer, just left it on them, and then find out how much steps they're taking per week. So I think we need to find different ways to motivate our patients to get enough physical activity.
I think one of the ways we discuss among ourselves is we can, as an hospital, also organize maybe a weekend workouts.
Absolutely, that's
session.
a good one actually.
That's just to see, by the time they see the health worker that has been talking to them also
doing it
with them, that's
motivates
them the motivation. So for both primary prevention, it is important, but we should also not forget that for those with secondary, there may be some residual deficits. So with the help of their physical therapist, with the help of the physiotherapist, they also will be able to achieve some degree of physical activity that will improve their outcome.
Absolutely. So I think the easiest thing to do as a physician is, number one, is to tell the patient how much physical activity is required of them to do and tell them why. That's one. And then secondly, we need to ask them from time to time. Asking them from time to time, just the thoughts that you know that your doctor will ask for this, is likely going to motivate them to do it. Some people I tell to keep the record at the end of every week, just like they're recording their blood pressure and things. Please record how many minutes exercise you did, so that in those, if it's 0, 0, 0, they write it there, and then it's just some sort of accountability, so to say. It encourages them to do it. And of course, many patients have various reasons. I actually wanted to do a study on that once. Have various reasons why they're unable to do enough physical activity. For some, it's pains. For some, it's lack of time, logistics. For some, it's they're not even sure the kind of exercise they can do. And then for some, sometimes recently, it's been insecurity, and they don't want to go out to the neighborhood. They're afraid of being kidnapped and things like that. Okay, but we should try to understand these problems from the patient's perspective and actually work with them in finding solutions and alternatives on what they can do. For some people, I settle with indoor exercise and just do aerobics in front of the television, or play something on your phone and do something.
Yes,
so
that's important, because lately a lot of our patients has been complaining. The main challenge has been security.
Absolutely.
We can no longer go out early in the morning, this because of security. So I encourage them indoor.
Absolutely.
Try as much as do the best you can do.
Okay, so that's so much for physical inactivity. So of course, we know that obesity too can contribute a huge cardiovascular risk. And I think all the things we mentioned earlier, in terms of exercise, diets, I'm not sure we still have a slide on diet later. All of those will go a long way in reducing someone's risk of a stroke. Okay, but sleep apnea is something that we are under addressing in Nigeria.
Yes.
As obesity rate is increasing, tobacco smoking increasing, sleep apnea is likely going to increase in the general population. And again, this drives hypertension, drives diabetes, drives stress, and drives stroke risk as well. So what do we need to do about sleep apnea?
It's actually a neglected risk factor that we've not been looking for. And about 75% of patients with TIA, stroke, they have sleep apnea. So sleep study is one of the things that we should cultivate the habit of doing. I know it's just coming up in the country, but I know the facilities are available for us to do a sleep study to be able to identify what the apnea-hypopnea index is. And once you have more than 5, the patient has sleep apnea. The higher the number, the greater the worse the sleep apnea is, and the greater the risk
that it poses for the patient.
So we need to look after this and address it adequately.
I will remember that as at like maybe a year or two ago, most of the patients I've seen on CPAP were actually diagnosed and prescribed in the US or Dubai.
Outside the country.
So it's something that we need to pay more attention to as physicians. When should we suspect that a patient may have sleep apnea? What should raise our suspicion for possible sleep apnea in the patient?
The patient will start that during the day they are not active, they just feel like sleeping.
And they feel tired.
They are not active. Somebody is sitting, discussing with you in the next few minutes, sleeping and snoring because of the frequent breaks they have at night. So they sleep, wake up, sleep, wake up, sleep, wake up. So the sleep is not sound.
Okay.
So that's alone. Then the partner maybe even be the one complaining that the way this man snores, and then sometimes it's as if he's stopping breathing. The breathing stopped intermittently. I have to wake him up. So those are the patients that should be looked into.
Additionally, so we have those kind of patients that if you see a patient that is very big, a patient with a big neck, a patient with one particular kind of voice, I don't know how to describe that voice now, and then people who have chronic or recurrent sinusitis. So when we see those kind of patients too, we should put in mind that we might be having, particularly if they have hypertension that is difficult to control, always just raging in the office, blood pressure always raging in the office, blood sugar difficult to control, and those kind of things. Those people may have a OSA. And like Dr. Shogalu said recently, those people, if you just treat the obstructive sleep apnea, you just see the blood pressure control just become easy. In fact, you take up medication and all those things. So something we have to look forward to. I think we're starting our sleep studies soon, actually. We're likely starting it maybe before the end of next month, so that at least we'll be identifying those patients better, and then of course, hopefully the CPAP will come to their rescue. So I think I'm actually quite glad that we did mention sleep apnea as part of the treatable and modifiable risk factors for a stroke care. So other behavioral related things, tobacco smoking and alcohol use.
Smoking, alcohol, diet, smoking like we talked about. Smoking has to be stopped. All measures aimed at stopping smoking we should implement.
So I still saw someone this afternoon, is a smoker, I think we saw for chest pain and some other likely coronary artery disease. So he has been smoking for several years. He still does about 10 sticks per day. But what I know as physicians is that, at least in Nigeria, we've not been offering enough counseling and support for people who are trying to stop smoking. I know that in UK, for instance, there are smoking cessation clinics. In fact, there are smoking cessation service that you just send the patient there. And once you send the patient there are things that they follow. So that's counseling, offering them things like nicotine patches. This person I saw this afternoon is not aware of nicotine patches or nicotine gums, okay? Not to now talk of the other medications that can make it easier for someone who genuinely wants to stop smoking. So I think we need to do better in that regard. Sadly speaking, smoking rates is increasing in Nigeria. It's increasing in Nigeria, particularly among the young population, where it's looking more fashionable. Unfortunately, that's likely going to translate to more coronary and coronary disease and stroke in the future. Regarding alcohol, I've had many patients ask me that, but it's red wine now. I take about 2 bottles a day, but it's red wine now. Don't you guys say that red wine? What's your take on that?
Non-drinkers should not be cancer to start drinking. About because we say maybe 2 units of alcohol for a male, 1 unit for female.
Absolutely.
So if the person is not drinking, don't start.
Okay.
But for those on it, we should advise them. And I think the challenge is, what is 1 unit? What is 2 units?
So for people who are drinkers, usually I advise them to moderate, to take very minimally if they can. And then, of course, red wine may be beneficial compared to other forms of alcohol. They can be encouraged to switch to that. About a bottle of red wine is about 12 units. So a glass of red wine is about 3 units. So, but of course, it's difficult to, but usually what I try to do is actually just to explain to that patient in terms of what he or she drinks. Yes. So what someone that takes spirit, for example, I tell them how many units that we are taking, what you should not take more than. Someone that takes beer, I explain to them in terms of beer, and someone that takes red wine, I explained to them in terms of the glasses. Okay, but it's better for someone that's had a stroke already. It's better to stop totally.
Yes.
It's better to stop totally. For people that don't drink, it's better not to drink. For people that drink, they should really moderate it. Consider switching to red wine and consider stopping if possible.
For secondary prevention, it's better to stop.
Absolutely, I agree with that.
Then we talked about the diet. So
okay,
the input of the dietitian is also important. So
I think we underutilize dietitians. We underutilize dietitians as doctors generally. Sometimes we feel
we know everything.
We know everything. We can do everything. But even if you know everything, you can't have time to do everything as a doctor. So you should. Everybody with a chronic disorder that is as diet as part of the management should actually be seen by a dietitian. Be seen by a qualified dietitian. Sometimes, because I've seen it make a lot of difference for many people. So I think I'll encourage our doctors this afternoon to work with their dietitians so that by altering the diet can help in weight management, cholesterol control, and control of the blood pressure. So I think those are the key risk factors before we go to the big one in the building, that's atrial fibrillation. I know that atrial fibrillation is one of your areas of interest. So what's the relationship between atrial fibrillation and stroke, Dr. Alekam?
Like atrial fibrillation, there is disorganized atrial contraction. So the atrium is not contracting as a unit.
Okay.
So there's increased risk of blood settling in the atrium and clot forming. Okay. And this clot can easily be transported into any of the cerebral vessels to cause
even the systemic vessels as well.
Stroke. It could also go systemic vessels, it will even go into the coronary circulation to cause problems.
So, for example, in the case that we discussed earlier, who had a paroxysmal atrial fibrillation and ended up having a stroke, what kind of atrial fibrillation increases the risk of stroke?
All types
of atrial fibrillation. So even people with
permanent. Wow. All type of strokes, all type of atrial fibrillation increase
the risk of stroke
almost 20 times.
Wow. So by how many times does atrial fibrillation increase stroke risk?
Like I said, almost about 20 times increase in stroke in someone with atrial fibrillation, even if it is a paroxysmal atrial fibrillation. So
that means you cannot separate atrial fibrillation and stroke.
Yes.
Stroke is part and parcel of atrial fibrillation.
It's part and parcel of, and I think we can remember one of our Caucasian guests that we saw that had atrial fibrillation, and before we knew it,
had a stroke.
Of
course, I saw one of our clients this afternoon that has atrial flutter, and he remains on rivaroxaban till date just because of the risk for stroke from that atrial fibrillation. And sometimes, in the conservative nature of we Nigerian doctors, many times we've had many patients who have atrial fibrillation and have the risk for stroke, but because you're afraid of maybe bleeding and you're afraid of what would the patient say, can I really use a blood thin and all of those, and then we leave the patient on nothing.
The drug is expensive, but by the time you look at the risk of not doing the right thing, you will discover that all your reservation amounts to nothing.
I'm not sure if you can remember this, my elderly woman that I see, 86 years, I don't want to mention her name, but 86-year-old woman in 80s that works with a stroke like this. She has had atrial fibrillation since her UK days. She has been on warfarin actually, but she was under warfarin. She was on this low dose, and that was just because she doesn't want to be doing her INR frequently. Of course, just like a trip in the high, she was just brought in one day with a stroke. Thankfully, they brought her on time. They brought her within 30 minutes of the stroke. Yes, we did not thrombolize, but by appropriate management, she made virtually a full recovery, actually. But the line is that stroke risk is real in atrial fibrillation.
It is very, very real.
And the disability may not be palatable.
Yes.
Okay, so I can see on your slide here that atrial fibrillation is also associated with ischemic stroke.
Yes.
Even silent atrial fibrillation.
That's
when interesting.
There's no symptoms, no palpitations, no dizziness, nothing. And it is just maybe an accidental ECG finding.
So in your take, do you think we physicians are doing enough about atrial fibrillation and stroke?
We are not doing enough because we are not even screening enough.
Okay, before we go further, please let's take some questions, Dr. Alekam. So I'll just read the question in the chat box now, in the Q&A box, and so that we don't go ahead of our audience. Okay, so I have this comment first of all here. Thank you for the presentation. What are the key symptoms to distinguish between ischemic and hemorrhagic stroke?
They still want to take us to where we don't want to go. We can just mention some few distinguishing factors using our popular theory that there's some things that you can pick from the history that suggests that this patient is likely having, mark the word, likely having. Neuroimaging is the final habitat. History of headache, history of vomiting, history of seizure, history of activity
at the time of
events. This, I think,
I'm very high blood pressure.
All this may suggest that it's likely hemorrhagic stroke and not ischemic.
But they're not reliable.
Yes.
But they're not reliable. Okay, so someone says that, so if you want to treat stroke well, you need to do neuroimaging.
Yes.
You cannot do a proper blood pressure control without good neuroimaging. And again, you cannot even talk about whether you want to thrombolize or not, whether you want to do embolectomy or not without neuroimaging. So neuroimaging is critical. So someone says here that for smoking, how is pack years calculated? So I'll just quickly tell us that. So a pack year is smoking a pack a day for 1 year. That's a pack year. So a pack contains 26. So if I smoke 26 for 1 year, that's a pack year. If you want to now make small conversions to that, if I smoke 1 stick a day for 20 years, that's 1 pack year too. I don't know if you understand.
Number of sticks over the pack is 20. So number of sticks taken per day over 20 times the number of years.
Absolutely. So that's how pack year is calculated. And then what we should put in mind is that for atherosclerotic related events, many studies suggest that the risk of atherosclerosis or of thrombotic related issues reduces within about 3 to 4 years of stopping smoking.
Yes.
Greatly reduces. So no matter how long someone has smoked for, there's still a lot of benefits in stopping. Of course, it doesn't follow the same for the risk of lung cancer and other things. Okay, but for atherosclerotic and thrombotic related issues, the risk actually rapidly goes down within a few years after smoking cessation. Okay, so someone asked whether it is possible to get the slides. Yes, the slides will be sent after the presentations. I can see this question here. What are the role of antioxidants, cobalamin, aspirin, in the management of stroke? Okay, so for aspirin, the role of aspirin in managing stroke now is clear cut. Okay, we know that after an acute thrombotic event, using aspirin acutely can improve the outcome of that thrombotic event. Because why? When there's a plaque rupture, we're talking ischemic stroke now. When there's a plaque rupture, the platelet aggregation is part of what forms the thrombus that eventually occludes the artery. So using aspirin to abort that platelet aggregation and the formation of the thrombus can improve the outcome of that stroke. Okay, and of course, in long-term prevention of stroke, we know that plaque is there. So long-term use of aspirin will reduce the risk of other thrombotic and occlusive events. So, but the role of antioxidants generally in management of stroke is very weak. The evidence is not strong and it's controversial. But several years ago, where I used to work, we used to use vitamin E and C, but we don't prescribe that anymore. We use some other vitamins now, but the evidence base for their use is not strong, and so it's mostly maybe anecdotal, I might say, but it's used to a varying extent in different centers.
I'm talking about aspirin. Again, the role of imaging. We must be sure that we're dealing with ischemic stroke before we prescribe aspirin.
I've seen someone not too long ago, actually, that was given aspirin soon after a stroke, but it turned out to be hemorrhagic, a big hemorrhage. Yes, the person pulled through, but when he realized that the aspirin that was given could have worsened the outcome of his stroke, he wasn't happy. So as much as possible, we should don't forget the line. First of all, do no harm.
Yes.
So we should be sure of the stroke type before we give anything that may potentially worsen the stroke. Any ideas about the prognosis of hypertension diagnosed at a young age? For example, about 30. The prognosis of hypertension diagnosed at a young age, in the short term is better, okay, but in the long term is not so good. In the short term is better because cardiovascular risk occur cumulatively. So if someone has high blood pressure, but the age is favorable, the 10-year risk of stroke is probably not as high as someone that is a 60-year-old. But if you're talking about the lifetime risk, it's going to be higher because the person has many more years to live.
Then there's even high possibility of a treatable cause of the blood pressure in a younger
age group
person. So that improves the short-term prognosis, but long-term, the risk is equally the same.
Okay, so it's also asked there, what's the risk of stroke or cardiovascular events, assuming no other comorbidities? Well, it will be difficult to put a figure exactly on that, but don't forget what we said earlier in the presentation, that above the age of 25, the lifetime risk of a stroke is more than 25%. That is more than 1 in 4 people above the age of 5 will have. So by the time you add hypertension to the equation, the risk will go to about 1 in 3 or something like that. So the risk will be in somewhere in that range. The next question here asks, if starting antihypertensive is contraindicated in the first 5 to 7 days following an ischemic stroke, when is it advised to start antihypertensive following an ischemic stroke? So management of hypertension, maybe I should leave Dr. Aliko to answer that.
We'll answer it in different ways. If it's a patient that you want to thrombolyze and the blood pressure is higher than the cutoff, greater than 180, 110, you may need to give antihypertensive even within that acute phase to bring the blood pressure down and be able to do your thrombolysis. That's one. 2, if the mean arterial blood pressure is greater than 145 millimeter of mercury, you need to intervene, even if it is few hours after the stroke. But in the absence of those 2, you need to wait out the acute phase of stroke before you give your antihypertensive. So this is not, we've seen a trend of patient presenting, the blood pressure is high, sublingual 930p.
And then you crash the blood pressure.
The
ischemic penumbra widens so much, or you see even new watershed infarcts in such patients. So it's important to know that. And then in the absence of those initial 2 indications we mentioned, usually the recommended practice is to wait out of the acute phase, which has to be at least 5 days before antihypertensives are considered. And that should always be done under specialist guidance. I'll remind us for that. Okay, so another question is I would like you to throw more light on alcohol as a risk factor for stroke. I've heard some statements about alcohol being cardioprotective. Is this real? How can we counsel patients in this regard? I think we've discussed that to some extent already. Excessive alcohol consumption is definitely a risk factor for stroke, especially hemorrhagic stroke. And that was also documented in the Cyrene study. So excessive alcohol consumption has a lot of effects, including some worsens blood pressure control, increased risk of obesity, and many of the other risk factors. So, but of course, many studies has shown us or suggested that consumption of moderate, minimal to moderate amount of alcohol, particularly red wine and other alcohol types that have some flavonoids, may have some cardioprotective effect if it's left at that level. But the advice that we recommend for patients remains the advice that we gave just earlier on, and that will remain that people who don't take alcohol, encourage them not to take or not to start alcohol. Those that take, advise them to take in moderation. If they don't stop, advise them to take in moderation. And those that take in moderation, you can try to encourage them to use the kind of alcohol that has been shown to have those little cardioprotective effects. That's like red wine and things like that. We should not also forget that there's a steep slope with alcohol. So, for example, if you tell someone that maybe start alcohol for your heart, you can take just a glass a day, you can come back in 6 months' time and see that person taking 1 carton every day. So, alcohol is addictive to some extent, and people may not be able to use it responsibly when in those cases. So, I think we'll go back to the slide now so that we finish on time. Excuse me here, please. 10 minutes. Wow. Okay, so we're almost out of time, and we need to speed up a bit. Excuse me. Okay, so we're still talking about atrial fibrillation now. So stroke prevention in atrial fibrillation. We don't have a lot of time, Dr. Laleka, so we
So
need to
we have
restrict
to
it.
just quick. Like I said, atrial fibrillation is an important risk factor for cardioembolic stroke.
Absolutely.
So we need to work on that. Assess the patient, the CHART score, CHART-VAS score, we should assess.
Dr. Laleka, wait, slow it down now. We're talking to a lot of people here now. When should the doctor suspect that there could be atrial fibrillation in a patient that they are managing with hypertension or they're sick or whatever?
So, patient comes to you with palpitation, dizziness,
or on routine examination of the pulse, you found that the pulse was irregular. Particularly if it's irregular. But by the time we notice some irregularity in the pulse, we should have a low threshold for doing ECG.
Once the pulse is not regular, please do an ECG.
And it has been argued that even perhaps everybody with hypertension should have an ECG. That's what we practice here.
It's even part of the World Health Organization baseline. Apart from blood tests, there should be at least an ECG. So you do an ECG, and then routinely, like I said, we're talking of both the primary prevention and secondary prevention. Every patient with stroke should have a rest ECG and should have an alter ECG done.
That's a
because we talked about paroxysmal atrial fibrillation. You can do the ECG and the ECG will be perfectly normal. But by the time you do a 24 or a 48-hour alter ECG, you will pick this up. So it is a recommendation, a guideline directed that must be done so that you will pick this up. And once you are able to identify that, the next thing is to identify the risk for stroke in these patients using the CHART score or the CHART-VAS score.
So can you just remind us of the score again?
So the CHART-VAS score, we talk about presence of hypertension, heart failure, the age, diabetes, presence of vascular disease, peripheral arterial disease, the gender.
Absolutely.
And once someone has a score of one, you should consider an agent. And by the time there is 2 in male, there is 3 in female, the person should be on an anticoagulant. Present guideline does not support the use of antiplatelets for patients that has scores of 2 and above. So, and also the present guideline also encourage the use of novel non-vitamin K oral anticoagulants as against warfarin.
And those agents are incredibly easy to use. No need for monitoring.
No dietary
changes. The drug is easy to use. So just simple and straightforward. You don't need to be checking high now, on and off, now and then. So basically what you've told us now is that I'm not sure how many of us know this MD Calc app. Also, it's also on Medscape. There are simple apps in which you can use to calculate this CHART-VAS score such that you can just quickly input all the parameters and you can get guidance on whether a patient should just be on no anticoagulant is needed, particularly for things like the lone atrial fibrillation, or whether the person needs to be on full anticoagulation or we should just consider it. So I think if we do more in this regard, I think most of the strokes that are related to atrial fibrillation
will be prevented and recurrence too will be also reduced.
Absolutely. So in comparing the novel anticoagulant agents, which ones do you have experience with?
Good experience with rivaroxaban.
Absolutely.
With proven results from different studies.
Absolutely.
Like rockets, the risk reduction is there.
Yeah.
The risk of fatal bleeding is even reduced when you use some of these agents in addition to the other advantage and it can even be used in patients with kidney impairments at a reduced and monitored dose.
So I think out of all of these nuts, I know that dabigatran was one that first became available in Nigeria, but recently we've had rivaroxaban added to the mix. So apixaban is also available in some pockets of places, but not that common. But I think one of the major advantages of rivaroxaban over dabigatran is the fact that you have the once daily dosing for it. But both agents are excellent in and easier to use compared to warfarin. There are a lot of restrictions to warfarin. I think I'll just mention some of them. We mentioned them just now. Number one is that there's a lot of dietary interactions, particularly with vegetables and food items that are high in vitamin K. So you can have those interactions, and your INR can just keep zapping from up to down. Today you do the INR is 10 point something, and then you do it 3 days time is 3 point something. So we have that issue with warfarin, and then of course, so the dietary restrictions, and of course you have to be checking the INR from time to time.
Yes.
The best people that are able to enjoy their warfarin are people actually that have the INR machine,
Yes.
which is costly. Our patient that we have recently, so which is expensive. Unfortunately, in countries like UK and US, they actually give them this machine. People that are on blood thinners like warfarin. Okay, but that's not really available here. So I think usually the NOACs, like rivaroxaban and dabigatran, will be our best bets here. It's important to mention atrial fibrillation while we're talking about stroke, because the risk of stroke in someone with atrial fibrillation is actually very high. It's very high. I can't count the number of people I've seen who have had stroke as a result of their atrial fibrillations before. Okay, so I think it's good that we've noted that now. I think we'll just have to rush.
We've talked about
this a bit. Okay, so in patients who have had ischemic stroke acutely from atrial fibrillation, is actually ideally it's recommended, even though the evidence rate is relatively weak, it's recommended to wait a while.
Yes,
before you start
between 3 to 2 weeks before you recommence.
It's just to reduce the risk of hemorrhagic conversion of the impacted part of the brain. Okay, and then someone who has atrial fibrillation that suffers a TIA on stroke. If the person is currently on the anticoagulant, you should continue it and consider optimizing it in case it's not optimal. I think that goes to the case report that you discussed earlier.
Yes.
The man was already on dabigatran, rivaroxaban, and then the person had a stroke while on it. Of course, you should assess adherence issues before considering making further adjustments to the medications. I think we won't spend so much time on this. I know that we'll be having a short break now, in which we have a brief drug presentation. So hopefully they are ready now, but we'll just continue with one or two more points of this discussion now. We should remember that before we give any patients anticoagulants, even patients with atrial fibrillation, we should definitely do a brain scan to exclude intracranial imaging.
Yes, we must.
One thing I need to mention for our doctors again regarding stroke and CT scan is we should remember that during a CT scan acutely, even an MRI, acutely in a stroke, is not to show us the ischemic lesion. It can show it. If it shows it, glory to God. But we should remember that the impact may not show until even sometimes up to 48, 72 hours after a stroke. Okay, so the fact that you can see someone who had a sudden onset weakness of the right upper and lower limb, just right there in your front, and then you did a brain scan that appeared normal, it doesn't mean the person does not have a stroke. The person has a stroke. It's just that the lesion is not obvious either yet on the CT scan, and sometimes you
can rule out
hemorrhage. So the work of the initial CT scan is actually to rule out an hemorrhage. So that is important for us to note. It's important to note this so that strokes are treated as stroke, not like because the brain scan is normal and they continue managing as maybe malingering or something. So we should not do that as well.
Let's go.
Okay, so
about.
So the key thing I just want to mention now before we allow the pharmaceutical reps to start their presentation is that we should use things like antiplatelets judiciously.
Yes. Okay. Especially in non-cardioembolic stroke.
Absolutely.
Should be used adequately.
So we have a lot of people who should be on an antiplatelet agent are not on, and then we have a lot of people who have no business being on antiplatelet agents who are on aspirin. Because we see a lot of patients who believe that they're using aspirin for their high blood pressure. No, aspirin is not a treatment for high blood pressure. Aspirin is an antiplatelet that is warranted in people who have a certain level of risk, which is most appropriately calculated by using the ASCVD risk calculator. So aspirin is not a treatment for hypertension, that's one. And then we should, of course, I'm sure we are all aware that we had studies that came out in, I think, 2019 that showed us that the role of aspirin in primary prevention is not as robust as we thought. And on the basis of that, quite a number of people who were on aspirin before now should be considered to be pulled off it. And then, of course, the use of aspirin for primary prevention is more limited than we used to think, okay? But for someone who has had established cardiovascular disease, for example, the previous stroke, previous myocardial infarction, or demonstrable coronary artery disease, either by angina pectoralis or by stress tests or other things, those need to be on long-term antiplatelets permanently, actually, okay? Those are the people that, even if they say they have dyspepsia, you add omeprazole or lansoprazole to it, and they should continue.
You use clopidogrel.
Exactly, or use clopidogrel. So that's what we should note by the side. And of course, for primary prevention, by the time people's cardiovascular risk gets up to a certain extent, usually we say if you are 10 years, CVD risk is greater than 10%, then we should consider putting them on an antiplatelet. So I think that's a great point of suspension now. I think we'll allow the pharmaceutical rep to talk, and then we will take some more questions after. Oh, Dr. Ken is with us as well. So I think we'll get some comments after the pharmaceutical discussions. Okay, so we'll welcome Mr. Gideon from Bayer Pharmaceuticals. Mr. Gideon, are you with us, sir? Hello, Mr. Gideon.
Everybody. Yes, I can hear you. I've been standing by and listening to the great presentation. Thank you so much for that.
Thank you very much. The floor is yours, sir.
Okay. I would like to share my screen. I don't think I've been given the permission to do that. Okay, thank you very much. I hope we can. Yeah, okay. Yeah, let me share my screen.
Can you share your screen now?
It hasn't given me the access to share. It's saying only the host. Okay, yes, I can now.
Okay, beautiful.
Yes, I can now. Okay, is my screen visible right now?
Yes, it is.
Okay, good. So I can go. I will try to make it as fast as possible. Thank you so much, Dr. Ofisoye. Thank you so much, Dr. Lalikon. I've actually learned more, even though our product is directly linked to stroke and atrial fibrillation, but I've actually learned a lot. So today, of course, we'll still be discussing on something very similar to that. Most of the things we'll be seeing on my slides have actually been discussed, and I appreciate that for making my presentation easier. So, of course, as said, patients who have atrial fibrillation have an approximately 5-fold increase of risk of ischemic stroke. As you can see, other things like heart failure, hypertension, coronary artery disease, heart disease rather, they have lesser hazard ratio. So this actually shows that atrial fibrillation, which are the category of patients we focus on with our product rivaroxaban, are actually at high risk of having stroke. So, of course, I remember Dr. Olalekan and Dr. Ofisoye mentioned CHAD score, CHAD-VAS score. Yeah, so this is basically it. It was part of my slide. So when I heard them discussing it, I was glad. So, yeah, the more the CHAD score, like, of course, the more the CHAD score, the more the comorbidities a patient probably has. So, as you can see, some patients even have up to like 6. And according to CHAD-VAS score, some patients even have up to like 9. The point of this that I'm showing is that when Xarelto was being, before it was registered and put into the market, our phase 3, phase 4 studies, we actually used patients with high CHAD-VAS score. We used those with CHAD-VAS score above 3-4 of the CHAD-VAS score, which means those patients probably have their female gender vascular diseases, their age is, they are old, they are female, all those things. we chose those ones who are at higher risk just to show and prove the safety and efficacy that is associated with Xarelto. And as you can see, these are the different category of patients, their numbers according to their comorbidities that they have, that were used when we actually did one of our studies, Rocket AF. I remember Dr. Olalikon mentioned this. So these are the different patients that were used. As you can see, a lot of those patients even have they have comorbidities, they have 2, 3, 4 other things that they are dealing with. And when Xarelto was used, comparing with warfarin, there was a significant difference in the level of safety and efficacy, and even the ease of monitoring and increased adherence and compliance for the patients. So, and also according to the guideline, this is the 2012 guideline, but even newer guidelines also support the use of NOACs, that's the rivaroxaban, Xarelto, and other NOACs to be used after you've assessed the patient and you've assessed their heart-blood score and you've assessed the stroke risk. You've done the stroke risk assessment. Usually, NOACs are actually recommended for those patients with non-valvular atrial fibrillation. Of course, the ideal properties of an anticoagulant before a doctor, a consultant prescribes an anticoagulant, there are different things, different scenarios that the doctor will definitely consider. And of course, the ease of use, the wide therapeutic window, low interaction with other drugs, low interaction with food, fixed dosing, those are the things that doctors actually consider. And all these criteria, Xarelto is actually winning in every category. And there are also more categories when we talk about safety, efficacy, reduction in mortality, reduction in bleeding, that's fatal bleeding and all that. It is very reduced with Xarelto. So I would continue. Xarelto is actually a direct acting factor 10A inhibitor. And what it does basically is to stop the conversion of fibrinogen to fibrin, and of course, doing its property of an anticoagulant such way. Quickly, Xarelto is metabolized by 60% the liver and 33% the kidney. Of course, patients who have liver and kidney issues can still take, but we always say that depending on the case, of course, care should be taken. But patients who are renally impaired, who have liver impairment, they still use Xarelto. As a matter of fact, and as Dr. Olalikon mentioned, we also have a specific dose for category of patients who are already having renal impairments. The dose for stroke prevention, secondary stroke prevention for patients who have atrial fibrillation is actually 20 milligrams once daily, as it can be seen. That's for those with normal creatinine clearance. And for those with creatinine clearance less than 50, usually we say less than, once they are less than 50 and, above 15 mil per mil, we always ask and, we always advise that the 15 milligram is recommended for those category of patients. Also, I would also quickly want to talk about the home treatment of Xarelto, which is something that we are home treatment using Xarelto, which is something we've been actively promoting. There was a study that was done, we call it the HOT PE. It is literally the home treatment of patients with low risk pulmonary embolism with the oral factor XA inhibitor. I know we've been talking about stroke, but I just want to emphasize that a lot of our patients who can actually benefit from home treatment are not being treated from home, probably because of the conventional mode of treatment or how it has been, or different things. But this study actually showed that for patients who are managed from home, there is better outcome with them, starting from reduced healthcare resources, lower risk of hospital-acquired conditions, improved patient satisfaction. Even there is less stress, less workload on the doctor and even the hospital as a whole. So we always encourage that we should now try to give as much patients that can take the oral anticoagulant at home instead of the injectable or the warfarin where they have to monitor. We always advise that, okay, let them have this oral anticoagulant. It is safe, There is reduction in the frequency of use. It has been seen to have high efficacy, and they've used over different ranges of patients from low frailty to high frailty, and it has been seen that the results have been consistent with Xarelto. As you can see, they actually did a study using the normal dosing for pulmonary embolism here in this particular case. So they actually started with the 15 milligrams Xarelto twice daily. Then after 3 weeks, they continued with 20 milligrams twice daily or 15 milligrams in patients who have renal impairment. The results, the primary outcome was symptomatic recurrent VTE or pulmonary related death. It was actually reduced. Symptomatic recurrent VTE was the secondary outcome, all forms of mortality, the bleeding rate, hospital stay, mortality, hospitalization, rehospitalization, all those things were actually found to be reduced. And according to the graph that we can see now, this is based on the 3 months treatment with Xarelto at home. It was seen that our major bleeding was reduced to 1.2%. And as you can see, recurrent VTE was 0.6%. Recurrent PE was 0.6, which are all less than 1% in those category of patients. This actually proves to show that there is advantage when those patients are treated from home. There is a lot they can benefit from. So the guideline now recommends that patients with acute low-risk pulmonary embolism are discharged early from hospital and treated at home. Yes, I know that some stroke patients will need to monitor them in the hospital, for some time before we let them go. But even these stroke patients, as long as they are conscious, they can swallow their tablets, Xarelto is very, very, very indicated for them. So it later went to say that despite this, only 6% of those patients with stable PE are treated from home. So this is just trying to encourage physicians that we can actually treat more of our patients from home. It will reduce the patient burden on us. It would also increase the confidence these patients have in us that, yes, we are not even in the hospital, but the drug our doctor has given us is working magic, and we don't even need to monitor or pay any extra money, and it's easy to use. So without saying much, I would actually like to encourage us. Well, Xarelto, as we've done a lot of studies, we've done phase 3, phase 4 studies. Even right now, we are doing real life studies. We have a lot of real life studies. Currently, there's a study, Invictus study, that we are doing just to still prove that everything we've said about Xarelto is true and is evidenced in the studies and findings that we've done. So I would quickly, this is the dosage for treatment of VTE. For treatment of secondary prevention of stroke in patients with atrial fibrillation, we usually start with 20 milligrams once daily, throughout the period that they want to use. If it's a patient that is renally impaired, we recommend the 15 milligram volume. That's patients who have a creatinine clearance less than 50 ml per minute. We always recommend that they use the 15 milligram. But in this case, this is for VTE, this is for pulmonary embolism, for treatment of DVT. The recommended dose is 15 milligram twice daily. And of course, after 21 days, the patient continues with 20 milligram or 15 milligram if the patient has renal impairment. Then after 6 months, depending on the level of comorbidities and reoccurrence of VTE, the patient either take 10 milligram or 20 milligram. So I would like to just put this here. If there is any further inquiry, if there is any question that you don't want to ask here, or anything you would want me to provide to you as related to Xarelto and different management, Xarelto has up to like 9-10 indications. But of course, the ones we are currently promoting in Nigeria, about 4, that's the pulmonary embolism, the DVT, the secondary stroke prevention, we use for CAD, we use for PAD, a lot of things. So Xarelto actually has a lot more advantage than we are currently using it for. So there is basically no reason why our patients can't benefit from the good use of Xarelto. Thank you so much for your time. I know everyone has busy schedule. You've taken time out to be here. We really, really, really appreciate you from Bayer, and we thank you so much. Please, if you have any questions, if you have suggestions, if you have input, you have things you want to add to the fantastic work of Xarelto, now is a good time. Thank you so much for the time.
Thank you very much, Mr. Gideon. We thank Bayer Pharmaceuticals for that. Indeed, I agree that the NOACs or the DOACs, like we now call them, have actually a huge role to play. And they've made life easy for us compared to warfarin, which can be a nightmare sometimes. Dr. Kennedy, thank you for being part of this discussion and presentation. Of course, we've discussed many of the risk factors and the things regarding stroke prevention. Of course, we will want you to give some clarification on some parts. So someone asked earlier about the role of antioxidants in stroke prevention and in treatment of stroke. What's your comment on this, Chief?
Okay, thank you so much, sir. I want to appreciate the panelists and the organizers of this event. It's indeed an educative program. I want to tender my apology for joining so late. I was so busy in the clinic. So, but be that as it may, the portion of the presentation I met, I think I learned a lot myself. Talking about the role of antioxidants in stroke prevention. I think that the much evidence that is available today is for, the role of antioxidants is in the setting of acute stroke. And maybe a little additional benefit for, patients who have had a stroke, talking about secondary prevention of stroke. Okay, so, but for primary prevention of stroke, there is not enough evidence to show that there is benefits, from the use of antioxidants. Okay, so of course we cannot overemphasize the importance of antioxidants in the setting of acute stroke. If we cast our minds back to the cascade of event that occurs, following acute stroke, there is generation of free radical scavengers, which we all know can expand the penumbra to take up portion of the umbra, which is the core area of infarction, can get expanded to incorporate some of the penumbra. So antioxidants have been shown to slow down or alter the process, especially NMDA, generation.
Absolutely. Absolutely. So which of the antioxidants would you
Glutamate and all that, they come into the
acute stroke?
Yes, generally we talk of vitamin E, but it's not just enough to use vitamin E. There is this brand of vitamin E, tocotrienol. Tocotrienol comes in the preparation of Tocovid. It's been shown to be 40 times more potent than tocopherol, which is the regular vitamin E. So I will advocate that we should take advantage of these benefits. Tocotrienol is 40 times more potent than tocopherol. Okay, so that is the most commonly used one. Then we also use lipid lowering drug. They've also been found to have some, anti-inflammatory, which can benefit in terms of antioxidant property. So we are using statins not only to lower cholesterol acutely, but they have also been found to have anti-inflammatory property. And inflammation has a role to play in the cascade of events, that leads to stroke formation. Then we also talk of vitamin C, though we don't routinely prescribe vitamin C. It's also a potent antioxidant.
Thank you very much, Dr. Kennedy, for that comment. Someone asked that what can we say about stroke prevention in children? Someone that works in a children's hospital. What would your comment be about preventing stroke in children?
Well, very few conditions among children compared to adults actually are preventable in terms of, stroke. For those children with identifiable risk factors, we can always work around them. Hemoglobinopathy, sickle cell disease, some malformation, moya disease. If such children can be identified as having specific risk factor, we can work around them. As we all know, cardiovascular risk is less among children compared to adults. So stroke prevention is a subject that is largely applicable to the adult population. But of course, where identifiable risk factors, are present in children, we should also work to modify them.
Thank you very much, Dr. Kende. Someone is asking here, comparing using CT scan or MRI in diagnosing stroke. What's your comment on that?
Yeah, both modality of investigation are useful in evaluating stroke patients. But of course, it is important to draw the distinction, between the two. CT scan generally is more useful, it's more sensitive actually, and it's more useful.
Hello, we lost you. Hello. Okay.
In delineating lesion, MRI in delineating white matter lesions. Number two, a CT scan is very useful, very sensitive, much more sensitive than MRI in picking acute bleed. Okay, so where most times when we order cranial CT scan, the usefulness is not in diagnosing an acute stroke in the hyperacute phase. Okay, but the usefulness is much more to exclude a bleed. Okay, so CT scan is much more useful in diagnosing hemorrhagic stroke. MRI, on the other hand, has other modalities, we call them protocols. We talk of the diffusion weighted imaging, perfusion weighted imaging. These are imaging that are able to delineate area of infarction compared to ischemia. So MRI remains the gold standard for diagnosing acute ischemic stroke. However, where facility does not exist for MRI, you can still make do with CT scan. There are subtle changes that you may be able to see. Even though these changes are subtle, as we say they are, some radiologists may still miss it in the hyperacute phase of stroke. I'm talking of less than 4 to 6 hours of onset of stroke. You may not be able to see much, but of course, you may be able to see 3 or 4 telltale signs. There is the one we call middle cerebral artery, hyperdense middle cerebral artery sign. So you see the middle cerebral artery on the affected side is much more enhanced compared to the normal side. Number two, there is less prominence of the lentiform nucleus. Lentiform nucleus will mean the globus pallidus, the thalamus, and caudate nucleus, all those deep nuclei. They become less prominent on the affected side. In other words, you cannot make out the distinction. Then number three, the Sylvian fissure gets obliterated. Okay, so all these are as a result of the early changes, early edematous changes that occurs in acute stroke. So that way, a CT scan is also useful in hyperacute phase of ischemic stroke.
Thank you very much, Dr. Kennedy, for those additions. I would just ask you now, just by the side, because there's been some talk on alcohol. Like I see someone else asking about what's the effect of alcohol in relation to stroke risk and on the neurological system based on your experience?
Yeah, alcohol and stroke is a big area of discourse actually. And alcohol can have effect both on ischemic stroke and hemorrhagic stroke. For those who drink regularly, maybe heavily, we talk of drinking moderately. It's a misnomer really, because where do you draw the line? What is moderate to one person is just a starting point for another. And but we talk in terms of grammage of alcohol. So for those who drink moderately or heavily, they are more at risk of developing ischemic stroke. But for those who do binge drinking, they don't drink often, but they take heavy, shots, every drink at occasional period. Those ones are much more likely to develop hemorrhagic stroke. So alcohol, whichever way you look at it, constitutes a significant risk for cardiovascular events, cerebrovascular events.
Thank you very much for that answer. We'll still get a few questions back to you along the line, and then we'll have you to comment towards the end of the presentation. Dr. Alekon, there's this question here. Someone asking about a young adult presenting with multiple occasions with a blood pressure greater than 140/90. How should you manage towards preventing a stroke?
I think the first thing right from the beginning of the presentation is to actually establish whether the blood pressure is elevated or not.
Okay.
So this person needs to do an out of office
Reading.
BP assessment.
Absolutely.
Using an exploratory blood pressure profile.
So this is a typical situation in which a BPM or ambulatory blood pressure profile will come to the rescue.
Yes.
And we've seen people like this in which by the time you do the ABPM is a test ambulatory blood pressure monitoring, which someone has a blood pressure cuff strapped to the arm and attached to a monitor, which is the monitor itself. A person wears it for 24 hours.
Yes.
Okay. Absolutely. We do that regularly in cardio care. I think we do about maybe up to 10 or 15 of those a week. So someone does that, and usually for someone who has this kind of blood pressure that we're saying above 140/90, you can do it and the blood pressure is totally normal, and sometimes blood pressure can be higher than you even thought initially. So I think for this kind of blood pressure, particularly young people or making a new diagnosis of high blood pressure, an ambulatory blood pressure monitoring is very valuable.
And after establishing your diagnosis, you need to investigate for possible secondary causes, which is very common in young people age group. And history too.
Okay.
Substance abuse, all those social biases to hemoglobinopathy, genetic abnormalities, all those things need to be taken into consideration and appropriate investigations.
Okay, so there's another question here. What happens to a stroke patient with a blood pressure of say 170/115? What do you do in your facility in the way of neuroimaging to know if the stroke is hemorrhagic or an ischemic, and how do you manage the blood pressure?
If you are far from a neuroimaging facility and you have blood pressure of this with established stroke, you
Clinically.
can clinically establish the fact that the patient has stroke. With this BP, you don't need to panic. 117/115, you don't need to panic. There are other things you can do while still monitoring the BP. You look at the trend, the profile of the BP.
Absolutely.
And monitor other things. If there are signs suggestive of raised intracranial pressure, your decompression can come in. Appropriate position, use of appropriate decompressing agents. The one we commonly have here, monitor, while still following up your BP. So you look at the trend of the BP, and most of the time, by the time you do this initial acute measures, appropriate rehydration with normal saline, as we know, that's important to maintain cerebral perfusion, decompressing, appropriate positioning.
Absolutely.
You will discover that the blood pressure actually starts coming down on its own.
A lot of the blood pressure elevation following an active stroke, I'm sure Dr. Kennedy can talk for 2 hours on that. A lot of the blood pressure response, part of it is related to stress response.
Yes.
Part of it is also a countermeasure by the body to overcome the raised intracranial pressure and to maintain the cerebral perfusion.
Yes,
so I think we should follow what we just discussed earlier, that the only cases in which you should touch the blood pressure early in an ischemic stroke is when you are about to thrombolyze one, or when the MABP exceeds a certain level, usually about 145, when it poses a threat to other.
At that point, your systolic blood pressure will be around the range of 220, 200. Absolutely. Your diastolic will be around 120, thereabouts.
Absolutely. So I'll just take one or two other questions so that we don't abuse the time of our viewers. So someone is asking why stress is on the list of risk factors and also regular meat consumption. Well, those are factors that were described and identified from the Siren studies. And the role of psychosocial stress and cardiovascular events, particularly in triggering and precipitating cardiovascular events, have actually been well defined. Okay, so after a stressful period, whatever the kind of psychological or psychosocial stress that is going on, the risk of cardiovascular events around such periods is actually much higher. Okay, and they found that in this Siren study as well. And of course, regular meat consumption. I presume they were talking about red meat. Anyway,
yes, they're talking about
red meat increases the risk of stroke. This question is there. What's the symptom of high blood pressure for someone who has not had that before? I'll ask you that, Dr. Aishan. Would you want
to usually call hypertension a silent killer.
Absolutely, it's a silent killer.
So most people with high blood pressure have no symptoms.
Absolutely.
And most of the time, the first symptom that someone with high blood pressure may have will be stroke.
So many times
the
first symptom can actually be a cardiovascular event, and we don't want that.
So that's why we talked about primary prevention to know your number.
Absolutely.
That's one of the objectives. Know your number. Know your blood pressure.
Absolutely.
Know your blood sugar.
Okay, I think I would, because of time, I'll leave that. So someone's asking here that why is non-alcoholic wine not encouraged among the heart-friendly wines? I would think that what this person is talking about is all these dealcoholized wines. So wines in which the alcohol content has been removed. I suppose that will likely be heart-friendly, but I'm not sure there has been actually any studies that has actually looked at it. But it should be heart-friendly if it's actually 0% alcohol, like many of those alcohol claims to be.
And I also want to be sure that this person is also not talking about the sweetened, carbonated drinks.
Oh no, so that is not also definitely is not affected because that is affected with diabetes, obesity, hypertension, and all the other ones. Before I allow further comments, so someone says, what's the place of citicoline, nicardipine? I think I'll leave that part for the at the end of the presentation. I would just want to just remind us that we should take measures enough to reduce cardiovascular risk in our patients, both patients who have established cardiovascular events and patients who have not had a cardiovascular disease or events at all. Here in cardiac care, what we focus on is internal medicine and cardiovascular medicine. And regarding cardiovascular medicine, apart from the general clinical practice, we have a lot of procedures that we do, and those includes pacemaker insertion of ICDs, that's implantable cardiovascular defibrillators, and also insertion of CRT devices, that's cardiac resynchronization therapy. Of course, we do a lot of other complex procedures. We've had embolectomy done, peripheral arterial angiography and intervention with stents. Apart from that, we've also done, I'm looking forward to the time in which we'll be doing endovascular procedures in the brain.
Yes.
I know that's very high up there.
Yes.
For stroke. Hopefully we'll get there at some point. Hopefully we'll get there sometime. But at least in peripheral arteries now, we've been doing embolectomy in people who are found to have acute peripheral arterial disease, and we found that there's a clot and thrombus blocking those places. Apart from that, of course, the routine coronary angiography and stenting is also offered as well. So I think we should avail our patients that need this kind of services to that. And hopefully very soon, I'm not sure when, but hopefully within the next 1 or 2 quarters, we'll be starting our cardiac surgery. We still sent someone to Lagos 2 days ago to post cardiologist to have open heart surgery. The person was found to have multivessel arterial disease that was not amenable to percutaneous coronary intervention. So I think I just want to highlight all these parts.
Then we should not forget our other investigative modality to Holter ECG, 24 hours, 48 hours, stress ECG,
absolutely,
stress echocardiography.
Oh, that was very interesting actually. So stress echocardiography has a lot of benefits beyond stress ECG, particularly for people who meet some kind of criteria. So I think those are things we need to be able to recognize when patients need them and be able to utilize them appropriately. I think what happens is that many of us doctors, particularly practicing on the south areas like Nigeria, we get used to not using some investigative and some treatment modalities and just allowing patients to just suffer their condition, whereas these things are locally available. I can remember about 2 weeks ago when a patient was boasting to me that when he went to UK, they put an ambulatory blood pressure device on him and they monitored him for about 24 hours, and he came back and then they told him that before he could actually agree that indirect treatment for his high blood pressure. And I was like, this is something we do every day, and I was surprised. So I think we should be aware of this kind of modalities so that we utilize them appropriately. So I think this last question here, someone who has a blood pressure, someone asked this question, please, for someone constantly having a blood pressure, systolic of between 95 and 100, diastolic around 60. At what point is the person at risk of low blood pressure? I think I'll leave you to answer that before we allow Dr. Kendi to give us the round of notes.
Persistent BP below 90 systolic millimeter of mercury and below 60 with associated symptoms suggestive of hypoperfusion. That will qualify for hypertension. But the fact that someone has a BP of 100/60 does not mean the person has hypertension. So the person needs to be checked. And all these factors are dynamic factors. And that is one of the reasons why ambulatory blood pressure is also indicated, because when we look at your profile, we have the highest BP, the lowest BP, the average BP, before we can confidently make all these assertions that you are hypertensive. And it's possible the person is also on medication that may need adjustment. So the person needs a comprehensive review. It's not just a blanket answer.
So for someone that is on medication, if the average blood pressure is indeed like that, will likely possibly need some reduction in the medication. But it's good to look holistically and not act on isolated blood pressure figures like that. So I think, okay, so there's a few other questions popping up here. Won't have so much time for this now. I think I'll just, let me see the questions for Dr. Kennedy here. I know the question that was asked Dr. Kennedy, the role of citicoline and then the role of nicardipine. Chief, are you with us, sir? Dr. Kennedy?
Yes, thank you. Yeah, the question asking about the role of citicoline, that's somazina. Well, somazina is one of the novel drugs that came up in recent past with a lot of promises to help limit stroke burden. In as much as somazina has not been found to impact much on primary endpoint, which is death or life, it doesn't really impact on whether, it doesn't improve survival among stroke patients, but it's been found to improve, secondary outcome. When we talk of functional outcome, ability to be able to return back to previous functional status. Somazina has been shown in several studies done, but the limitation is that none of those studies were randomized controlled trial. But based on available evidence, it's been shown to improve on secondary outcome following stroke patients, in particular those who have moderate to severe form of stroke. Of course, it is those who have ischemic stroke, not hemorrhagic stroke. So that's a much. I wasn't using it previously, but I think in a little observation that I made in my center, I discovered that there were actually proven benefits, even though there are no randomized controlled trials yet. Yes, we noticed that hospital stay, is significantly shortened. And most of those patients also tend to return back, functional status improvement at 6 months, 3 months, and 6 months.
Seem better. Okay, so the same person also asked, hello, Chief, are you still there? Breaking.
Okay.
Maybe there was a significant, not on somazina. Okay.
So maybe I can just take the nicardipine and amlodipine. The difference is in the duration of action. Because when we are to use antihypertensive in stroke, especially when you want to use it that acute phase, you want to use drugs that are rapidly acting and have short duration of action. Short controlled duration of action. So that's why nicardipine is a calcium channel blocker, but it's short acting compared to amlodipine, which is a long acting. So you want gradual reduction of your BP. You don't want something that will bring down your blood pressure and that the effect will last for almost 24 hours. So that's why if you have nicardipine, you can actually give your patients in place of amlodipine.
Is it how available is it locally?
I know we used for one of our stroke patients recently. We got what it was not a bit easy as amlodipine and pedipine and the rest of it.
Chief Kennedy, I will ask you to help us round up this presentation on stroke prevention, sir.
Okay, thank you so much, sir. I'm sure that so much has been said, and our participants have a load of take-home points, to go with. So, stroke prevention, overall, hypertension still remains the biggest of the risk factor. As a matter of fact, 80 to 90% of risk of stroke is from hypertension alone. So, concerted effort should be targeted towards diagnosing hypertension and ensuring that our patients who are hypertensive take their medications regularly. Next to that would be factors such as diabetes, hyperlipidemia, obesity. Those are the modifiable risk factors. For the non-modifiable risk factors, there is little or nothing we can do about those ones. So for patients who have had a stroke, we should also take note that there's no cause to panic, especially blood pressure management. Is that aspect that actually determines whether a patient with stroke survives or not. So when a patient with acute stroke comes in with a severely elevated blood pressure, it's not to rush to lower blood pressure, especially when it is ischemic stroke. We should ask ourselves 4 questions. Is the patient in pain? Is the patient having urinary retention? Was the patient previously having chronic poorly controlled hypertension? Is the patient having a deterioration in renal function? These are major questions that should be asked. The 5th question is if the patient has had an elevated intracranial pressure. Normally, it's physiologic for blood pressure to go up following acute ischemic stroke. It is protective. It is meant to preserve cerebral perfusion pressure. And of course, the rule is don't touch the BP in the first 10 days for acute ischemic stroke. However, if there are reasons to touch the blood pressure, such reason will include persistently elevated blood pressure, 220 over 120 or MAP of greater than 145. When we say persistently, above more than 6 to 8 hours following admission. Otherwise, you should just observe. So catheterize your patient, relieve pain, give monitor if there are features of raised intracranial pressure, and in most instances, you may not need to treat blood pressure acutely. If it is hemorrhagic stroke, the approach is a bit different. There is a risk of hematoma expansion, so you don't want the elevated blood pressure to persist. You don't want the blood pressure to be persistently more than 180 over 110. The safe zone to be is to maintain the BP between 140 to 160 over 100 to 90 to 100. If you approach it that way, you are not likely to do any harm to the patient. Then secondary prevention, of course, should be emphasized among those who have had a stroke, especially ischemic stroke. Agents such as antiplatelets, statin, and maybe tocovir, then antihypertensive, calcium channel blocker and thiazide among elderly, maybe an ACE inhibitor among younger individuals. So I think with that, we should be able to have a good approach as stroke management.
Thank you very much, Dr. Kendi. We're very grateful. Dr. Lalekon, thank you for a fruitful and wonderful discussion as usual.
Very much.
We appreciate our audience. We don't take it lightly. Thank you for joining us this afternoon. We hope that we can continue to be mutually beneficial to each other as we learn, as we continue to rub minds, and we use these sessions to improve our clinical practice and improve outcomes for our patients. As much as many people have lost faith in healthcare system in Nigeria, we continue to have faith in it. I will continue to take measures to push the bar higher so that we continue to treat people better, and hopefully the health outcomes of our population and our patients will continue to follow that. Again, thank you very much, everybody, for attending. The video will be made available on YouTube. I'm not sure how soon it will be up, but it should be up maybe within the next 24, 48 hours. Okay, and hopefully we expect that we'll send this slide out in PDF format, again, within the next 24, 48 hours. Of course, the webinar is CME eligible. So for those of us that attended and participated, we'll be sending out the CM is within a short time. I'm not sure how soon. So again, thank you very much for attending. Hopefully, we are starting. April is coming very soon, and we're going to have interesting topics lined up for April. So once again, we appreciate everyone for joining us this afternoon. Dr. Lalekon, any comments for our audiences?
We appreciate you for your time
Okay.
And we hope that next topic will have you joining us so that we can learn from ourselves, improve our practice, and like we usually say, let's keep safe, face mask, hand washing. COVID is still available.
I will also want to encourage our audiences to utilize verbal comments and questions by using raise hand part of it, and then using raise hand part of it so that they can comment audio verbally. So that I think some people are more likely to interact better with that and understand that. So once again, I'll remind us that cardio care is at Giza close to FCDA Abuja, and of course we discussed earlier about the common specialist services that we provide. Apart from being a cardiology focus center, cardiology and internal medicine focus center, we have a cath lab. We do sort of device implantation, coronary angiography, dialysis. I think we have a consultant nephrologist that is joining us again next month. So we do all of that, and we hope that we can be mutually beneficial to each other. Enjoy your weekend. Have a wonderful evening, and hopefully we'll see you again at the next webinar in about a few weeks' time. Thank you very much, everybody.